Hello everyone, welcome to another session of next Saviours Essential Question Series NEET PG 2025. Today we are going to have a discussion on an important question where the ECGs are basically provided for the purpose of its identification. And let's see how these questions are asked. We are taking one question out of the practice paper which is there in the Essential for NEET PG 2025 question series available on next Saviours app. You see, the question reads as 18-year-old female presents with a history of recurrent respiratory tract infections. Now, during evaluation, her vital signs are stable and the physical examination revealed no significant abnormalities. The ECG was performed, showing a heart rate that varies with the respiratory cycle. And the ECG is given to you in the question. So, what is the most likely diagnosis the patient is suffering from? Now, you see, if you look at the ECG which is provided to you in the question, then the P waves are present before every QRS complexes. So that indicates that the rhythm is originating from the sinus node. So this is absolutely normal. Now, QRS complexes are narrow, but it is indicative of supraventricular origin, which is obviously a feature suggestive of normal conduction. Now, if you look at the rhythm, that means the distance in between R and R. So that is RR interval. So it varies. Now, if you look at here, that RR interval is larger in comparison to RR interval, which is seen over here. So there is a difference in between the two. And this rhythm is irregularly regular, but the pattern is still organized. So based on these evaluations, if you know that in the question there is a provision of the respiratory changes which is also mentioned. Now all of you are aware of the fact that sinus arrhythmia is a normal variation in the heart that occurs with breathing due to modulation of the vagal, that means parasympathetic tone on the SE node. Now what happens that during inspiration the vagal tone decreases and the heart rate increases. Similarly, during expiration the vagal tone it increases and the heart rate decreases. So this leads to the cyclical variation in the RR intervals on the ECG, while the rhythm remains of sinus in origin. That means P waves are present before every QRS complex. So this ECG, which is provided to you when coupled with the question asked, that means the theoretical points which are present in the question asked, the answer for that question obviously is sinus arrhythmia, because in the question it has been mentioned that there is a variability in the RR interval which is because of the respiratory cycle. It is classical of respiratory sinus arrhythmia, which is a normal physiological variant which is often seen in case of children, it is seen in case of young adults and in case of athletes. So obviously we came to know about the answer for this question, that it is sinus arrhythmia. But let's see how the ECGs for other option looks like. If you look in this ECG, the atrial activity is rapid, but it is regular, which is approximately pointing towards the rate of around 250 to 350 beats per minute. But there is no distinct P wave that could be identified. Now, if you look at the QRS complexes, they are also regular, but they are narrow, indicating normal ventricular conduction. Now, if you look at the conduction ratio, you see normally in a heart, the atria and the ventricles, they normally beat in the ratio of 1:1 because every atrial impulse, it gets conducted to the ventricles via the AV node. But in case of atrial flutters in particularly, the atria, it beats very rapidly. That means there is a heart rate of around 250 to almost 350 beats per minute, and AV node, it cannot conduct every atrial beat generated because it has a refractory period. So some of the impulses gets blocked and only every second or the third impulse it gets through the AV node into the ventricles. So this is resulting in a fixed conduction ratio. What does it mean? That if I say that the conduction ratio is 2:1, it means that every second atrial impulse is conducted to the ventricle. If I say it is 3:1, that means every third atrial impulse is conducted to the ventricle. So this is how in case of the ECGs which is provided over here, there is a appearance of the classical sawtooth baseline pattern along with the regular atrial activity with no distinct P waves, and the QRS complexes, although they are narrow or regular, but it is indicative of a normal ventricular conduction, and a fixed conduction ratio of around 2 is to 1 to 3 is to 1 is can be observed. So we are looking at the ECG of the atrial flutter. And you know, the definition of atrial flutter is that it is the supraventricular tachyarrhythmia which is characterized by rapid regular atrial contractions and sawtooth flutter waves, which is best seen in the second, third, and AVF leads. So this is how the atrial flutter ECG looks like. Another option provided to you is that of a ECG finding. Now, in the question, we have already seen that how the ECG of sinus arrhythmia looks like and the atrial flutter looks like. Let's see how the ECG of atrial fibrillation looks like. You see, there is a presence of irregular rhythms, and this is a hallmark of atrial fibrillation. Along with this, there is obviously no distinct P waves that you can identify. The QRS complexes obviously are narrow, but it is indicative of supraventricular origin, and the RR intervals are also variable. So you can say that in case of atrial fibrillation, how is it being identified on the ECG? There will be a presence of the disorganized rapid electrical activity in the atria because of the loss of coordinated atrial contraction. So it results in irregular rhythms or the ventricular response. And there is no distinct P wave that could be identified on the ECG. Now, you will say that, you know, majority of these findings are also present in the atrial flutter. So what are the differences in between the two? You see, in case of atrial flutter, there will be a sawtooth waves. Here, there will be an irregular baseline. Now, rhythms are regular or irregularly regular in case of flutter, but here this hallmark feature of irregular rhythms are present in case of atrial fibrillation. The rate obviously is in between 250 to 350, but here there could be a higher rate, which is obviously chaotic, and ventricular response is also regular, but here the ventricular response is irregular. As you can very easily identify that there is no regularity in any of the rhythm of the ECG which is provided over here in this question. So this is how the ECGs of atrial fibrillations are identified. And finally, what we are left with is the option of Wolff-Parkinson-White syndrome. So finally, before talking about the ECG findings, let's understand the pathophysiological mechanism of the Wolff-Parkinson-White syndrome. You see, normally the impulses, they go from the SA node to the AV node, and from the AV node to the Purkinje fibers, ultimately up to the ventricles. But in Wolff-Parkinson-White syndrome, what happens? Because of the bundle of Kent, some impulses, they skip the AV node and reach the ventricles directly, causing early activation. But what happens in case of Wolff-Parkinson-White syndrome? Because of the presence of bundle of Kent, now some of the impulses, they skip the AV node and reach the ventricles directly, causing early activation. Now, this creates the delta wave on ECG. So, one of the findings that is about to be learned in case of Wolff-Parkinson-White syndrome is the delta wave. Now, presence of both normal as well as abnormal conduction causes a fusion complex. And this fusion complex will obviously be resulting in the widened QRS complex or widened QRS. So now it becomes much easier to understand that how the Wolff-Parkinson-White syndrome ECG will look like. Number one, obviously there's going to be a short PR interval because of the earlier appearance of the delta wave. So short PR segment. Second, there is a presence of the delta wave. That means an elevation, a slurred upstroke at the beginning of the QRS complex, which is due to the early ventricular activation through the accessory pathway, which is bundle of Kent. So this is how the delta waves are identified at the base of the QRS complex in the beginning. And obviously there is going to be a widened QRS complex, as we have already talked about, that it is because of ventricle which is depolarized normally as well as abnormally. So there is going to be a fusion leading to widening of the QRS complex, more, which is usually more than 120 of milliseconds. Now, What are the classical triad in case of ECG which is seen? One is the short PR interval, delta waves, and wide QRS complexes in Wolff-Parkinson-White syndrome. Now, one of the important association which might result in a hazard is that if the patient with the Wolff-Parkinson-White syndrome develops atrial fibrillation, then the chaotic atrial impulses may travel rapidly through that accessory pathway instead of being filtered by the AV node as we have just seen, so which can cause ventricular fibrillation. Now, this atrial fibrillation coupled with Wolff-Parkinson-White syndrome might result in ventricular fibrillation. So that is why it is recommended that never give AV nodal blockers like verapamil or digoxin in Wolff-Parkinson-White syndrome with atrial fibrillation as it can worsen the condition by enhancing the conduction through the accessory tract. So this is something that you have to learn, which is obviously provided to you in the explanations. And one of the accessory, just for the completion of the lecture and the knowledge, the Wolff-Parkinson-White syndrome also has to be differentiated from the Lown-Ganong-Levine syndrome. So Wolff-Parkinson-White involves the bundle of Kent and shows the delta wave and with the wide QRS complexes as we have already seen, while Lown-Ganong-Levine syndrome involves the James fibers, which bypasses the AV node but joins the bundle of His. So these are those James fibers, and it is identified by the short PR interval only. So hope the session was of help. Hope you have understood everything related to what was being provided to you in the question, and this is how it is being explained in the app itself. That here the key ECG features of the four syndromes are differentiated based on the ECG findings and the rhythms, because it is on the basis of the rhythm you will be able to differentiate in between the flutter and fibrillation, and the important ECG findings on the basis of which Wolff-Parkinson-White syndrome is identified. So all the best for your future examinations. Thank you very much for listening the lecture. In order not to miss any update, please join our Telegram group. The link is provided to you in the description.